We are live.
A very good evening to all of you. So once again, welcome to the platform of Department of Urology, SMS Medical College, Jaipur. We'll begin our session with offering a small prayer to Ma Saraswati.
Saraswati Namastubhyam Varde Kamarupini Vidyarambham Karishyami Siddhirbhavatu Me Sada.
Thank you.
Saraswati.
So welcome again to this webinar. So today's star attraction is a faculty talk by none other than Dr. Asukosh Tiwari, better known as Ash Tiwari in US. He is professor at Icahn School of Medicine at Mount Sinai. He is Kyung Hugh Kim Chair of the Department of Urology. He is also the System Chair, Department of Urology, Mount Sinai. He is also the Chair, Milton Carroll Petrie Department of Urology. He did his preliminary education in India, in Kanpur only. Did his MBBS and MS from there, and then did his MCH Urology from SGPGI Lucknow. Then he went to United States and did his residency at Henry Ford Hospital, Detroit. And then he did a lot of fellowships. One of them was transplant fellowship at Royal Liverpool University Hospital, UK. Then he did his Urologic Oncology Fellowship at University of California, UCSF, and then fellowship in prostate cancer at University of Florida. Dr. Tiwari has innumerable number of awards and achievements. It's not possible to enumerate all of them, but I would just name a few. He received the Gold Cystoscope Award in 2012, received the Most Compassionate Doctor Award by Vitals 2012, received the Yahya Cohen Memorial Lecture and Medal, College of Surgeons of Singapore, Sim Medal, Royal College of Surgeons of Edinburgh, BJU International Visiting Professor Award, Maine, Germany, and he also was judged as the America's Best Doctors and New York's Best Doctors in these years. He has almost more than 232 peer-reviewed articles in the major national and international journals. He has more than 39 books and book chapters, one of them being on prostate cancer, a comprehensive perspective. He has been the investigator in various ongoing trials. He is the associate editor of British Journal of Urology, and he has 2 patents to his name. One is on catheterless device and approach, and the other is patent for urethral catheterless radical prostatectomy. So he is not only a par excellence surgeon, clinician, and researcher, but he is also a par excellence human being. Recently, Dr. Tiwari and his Global Cancer Foundation and Baba Kalyani, Bharat Forge India, collaborated with Mr. Anupam Kher and his foundation to initiate a project called Project Heal India, and made a big contribution towards providing medical equipments for the COVID patient care, which are in extreme shortage in India recently. So we'll have a small video clip on what Dr. Anupam Kher has to say.
तो ये प्रोजेक्ट हील इंडिया का जो हमने मुहिम चलाया है, ये बेसिकली इसकी शुरुआत हुई डॉक्टर ऐश तिवारी से, जो हमारे मित्र हैं न्यूयॉर्क में, अमेरिका में, बहुत बड़े कैंसर के डॉक्टर हैं। उन्होंने इकट्ठा करके ये सामान भेजा है, वेंटिलेटर्स भेजे हैं, ऑक्सीजन कॉन्सनट्रेटर्स भेजे हैं, और भी बहुत सारा ऐसा मेडिकल का सामान भेजा है। हमारे जो फाउंडेशन है, अनुपम खेर फाउंडेशन की मदद से ये अलग अलग नीडी जो जगहें हैं, जहाँ हमने जो हॉस्पिटल्स आइडेंटिफाई किए हैं, जहाँ पर बहुत ज़्यादा सामान की ज़रूरत है, उतना लोगों के पास पैसा नहीं है, और जो उस तरह के, तो अलग अलग लोग हैं। जैसे ये पुणे में एक हॉस्पिटल में जा रहा है, ये जो है ये दूसरे एक और हॉस्पिटल में जा रहे हैं सारे बेसिकली। ये जम्मू में जा रहा है, जो जम्मू में जो शिविर में रहते हैं कश्मीरी लोग, उनके लिए जा रहा है। वैसे ये हाजीपुर बिहार में जा रहा है, ये अमेरिका से आया बाय एयरक्राफ्ट आया। अब यहाँ से जो भारत फोर्ज इंडिया है, जो बाबा कल्याणी की कंपनी है, वो लेकर जा रहे हैं। कुछ एयरक्राफ्ट से जा रहे हैं, कुछ बाय रोड जा रहे हैं, कुछ सारा जो भी ट्रांसपोर्ट का तरीका है वो भी वैसे ही जा रहे हैं।
So these are the ventilators and other devices and equipments that has been sent to India under this project for the COVID patients.
और इसमें सबसे ज़्यादा जो है वो भारत के बाहर रहने वाले हिंदुस्तानियों का बहुत बड़ा हाथ है। हम बार बार कहना चाहेंगे कि डॉक्टर आशुतोष तिवारी जो हैं बहुत बड़े डॉक्टर हैं, हमारे बड़े अच्छे मित्र हैं, और उन्होंने ही हमको अप्रोच किया।
So Dr. Asukosh Tiwari, in his own words, says that we may be 10,000 miles away, but we continue to keep you close in our hearts and thoughts. The supplies we are sending you are a kind of symbolic gesture and a sign of solidarity. Thank you, Dr. Tiwari, and we highly appreciate your kind gesture of contributing to the Project Heal India during this COVID crisis. On behalf of all the residents and staff of our Department of Urology, SMS Medical College, Jaipur, we feel honored to felicitate you on this occasion. Thank you very much to have come on this platform. Thank you, Dr. Tiwari. So today, yes.
You almost choked me. Please, I didn't expect this. Go for it.
Thank you, sir. Thank you. Today we have three special invitees with us. Dr. Mallikarjun, he is the Managing Director and Chief Consultant Urologist at Asian Institute of Nephrology and Urology, Hyderabad. He is presently our President of Urological Society of India, a pioneer in laparoscopic and robotic surgery, has organized numerous live workshops throughout the country and abroad, is a passionate teacher and mentor for many urologists. And his hospital, AINU, which is called AINU, this is a state-of-the-art hospital and has been adjudged as one of the world's best hospitals by the Newsweek. So welcome, Dr. Mallikarjun.
Thank you, Shivam.
Thank you, sir. Thank you. And then we have Dr. R. Keshavamurthy, who is professor and head of the department at Institute of Nephrology and Urology, Bangalore. He is presently our honorary secretary of Urological Society of India. Welcome, Dr. Keshavamurthy. Thanks for sparing your valuable time with us.
Thank you, Dr. Shivam. Pleasure to be with you.
And then we have Dr. Anil Helens, who is also the Executive Council member of Urological Society of India, is the Chief Urology Consultant and Medical Director at Dhanvantri Hospital. He was the past president of North Zone Chapter of Urological Society of India, is presently the president of Meerut Urological Association. Dr. Anil, you are most welcome to our platform here.
Thank you, Shivam, and it's a pleasure to be with Ash, and it brings back memories of our great times we spent in SGPG, and our association with Asukosh. It now spans over 3 decades and more, and it's always a pleasure to be with him and hear him speak. And he's so passionate about this topic, and I look forward to this talk. Thank you.
I would now call upon Dr. Mallikarjun to say a few words on behalf of Urological Society of India. Please,
I think, thank you, Shivam. Let me be very short. First of all, I should appreciate on behalf of Urological Society of India, Dr. Ash Tiwari, for his generous contributions and efforts, more than anything else, efforts to get the equipment into India for the needy people in India, irrespective of the destination. He was telling that. It was so it is really, it goes pimples onto me when he says that word, saying that destination is immaterial. It should go to the needy. Thank you, Ash, for that sort of an effort, what you put all the time. And more than that, it's the residents are going through a big phase of non-training because of this COVID, and many people are not getting into that real training mode past 1 year because of the COVID. And you taking out some time in this resident teaching program, though it was meant for SMS residents, I think you take it for granted. All the 1,500 residents in India are at present glued to this program for all purposes. Thank you very much for spending some time on a busy working day from yourselves. Thanks. You're on behalf of us, from by heart, from Urological Society of India.
Thank you, Dr. Mallikarjun. I would, because Dr. Keshavamurthy has to leave, I would request Dr. Keshamurthy to give a few words.
Thank
I just speak a few words.
Thank you, Dr. Shivam, for having us. And on behalf of the Urological Society of India, I echo the sentiments which are President of the USI. And I congratulate Dr. Asukosh Tiwari for the generous contribution which he has done through Project Heal India. We are grateful to you, sir, for this wonderful gesture of yours. And I'm sure the residents would be benefited by your talk today. And that's all. And we would hope that you would be in Ahmedabad for the UCCon 2022. We would want to meet you in person.
Thank you,
Thank
Dr.
you, Shiv.
Keshamurthy. Now it's a proud moment for me to call upon our faculty, Dr. Asukosh Tiwari. He has been a pioneer in robotic surgery and has made a significant impact on the anatomical foundations as they apply to robotic platforms, and has performed over 7,000 robotic radical prostatectomies. He is a clinical scientist who has made seminal contributions to prostate cancer research. So, Dr. Asukosh Tiwari, you are most welcome to our platform, and over to you.
After this introduction, I don't know, I have my voice back with me. So you guys are so generous, and we didn't do anything. We just reacted as anyone else would. And that reaction, when you do, a lot of people start helping. And it started with my own team here, and then Baba and Anupam. And let's change topics. It's just making me become a little bit emotional. So while I'm getting my slides up, I have a special story about actually SMS Medical College. So you may not know that before getting to urology at Sanjay Gandhi as an MCH candidate, I was doing a GI fellowship under Dr. Samiran Nandi in All India Institute of Medical Sciences. And I myself had kidney stones. I myself had hematuria for over a year when I was in medical school. So urology was a very sought after thing. And my parents always tried to get me to see someone who was a urologist. And in Kanpur, it was not easy to get to see a urologist because there were not that many in 80s and 89 to that time frame. So I somehow found out about Dr. K.C. Ganguwal. And I took a bus ride to come to Jaipur, and I stayed there there was in Bhagwan Das Road or something. And there was a place I found. I stayed there for a few days because that was one of the most legit urology programs at that time, where Dr. Ganguwal had established the department. And there you go, 30 years later, I'm back in here. And he is the one who kind of got me stimulated into urology. I saw PERGs being done, I saw TURs being done, and I had never seen anything of that kind before. And then I got into to Sanjay Gandhi as an MCH candidate and all those things. So SMS has a special place in my heart because Dr. Ganguwal gave me a direction towards urology. Let's change gears, and we learn in our journey, and we learn from different sources. And I want you to think about that there are things which are outside medicine, which can sometimes teach us what we want to do in medicine. And I want the residents to remember 3 words which will sum up my talk at the end of it. It may not make sense in the beginning, but at the end, these 3 terms may give a summary. So one term is about harness. Harness, which a rock climber puts on to secure things, and harness has a shape. So we will talk about harness. Second term I will talk about is a hammock, and third term will be a hood. It's simple way to remember what this entire journey has been for me. So I want you to watch this video and see if you can feel the emotions.
Ampie croce, 15 minuti dal boulder problem.
I will stop right here and I'll give you a background. This is from a movie known as Free Solo. And this is about a rock in California known as El Capitan. And that was 3,000 feet high rock. And it's a sheer rock face, which people find it very difficult to do a rock climbing. Doing a rock climbing itself is an achievement, but this guy wanted to do it without any ropes. That's the reason this movie was known as Free Solo. And how he did it, what he did to get to this point, and what he is doing right now, this is known as karate kick. I will come on to that term. He had broken up this entire journey into different segments, and one part was known as a boulder problem. And the boulder problem had two options, either to jump or to do this, what he is doing right now, karate kick. Bottom line is, in this entire move, anything not going right would have meant that he will die. His life dependent on this preparation. Same thing we are going through in our life, what we call when we do the surgeries, actually someone else's life is depending in our hands. And it's not just the life, most of the time, it's the sexual function, urinary function, cancer coming back, and all those things. So this will give you a feel about that, why I chose the term harness, and I'll bring it that term again back to start with my slide. And so this is the guy, his name is Alex Henold. He's the guy who has done it and still is alive so far. He is a gifted mountain climber, rock climber, and I kind of observe him not for becoming a rock climber discussion, but to learn from what he had to go through to do what he ended up doing it. And can I bring those concepts back to when I'm doing the surgery? So I'm giving you a feel about why understanding the anatomy was an important tool in my hands to modify this operation. Prostate cancer surgery is one of the unique surgeries in which surgeon is judged not just by what he or she takes it out, but by what he or she leaves behind. The muscles which control urinary function, the nerves which control erectile function, they are all very intermingled around. And this is a picture done by my team in which they have stained prostate cancer cells with the PSMA and the nerves as an SA100 stain. And you can see nerves are passing through and through the cancer. So there are not many cancers. Pancreas may be one, certain other kind of rare cancers may happen, but the perineural invasion is a phenomena which happens in prostate cancer. And as a surgeon, we have to take the cancer out, and yet we have to focus on saving the nerves and saving the function. So there are three unique circles they are intermingling in this operation. And that's the reason this is a little bit complex operation. It's not something I have to take the bulk out. I still remember early on in my general surgery days in India, I mean, I will take literally 3 kilogram ovarian tumor out. It looks very impressive that I took something big out, and but there was, as long as I don't injure any organ, the bleeding is not there, this ligature doesn't slip or suture doesn't slip, we were fine. But here is an operation where we have to focus on margins, we have to focus on erections, and we have to focus on continence. And each one of them has their own nuances. So get the perfect in the center needs a lot of preparation. And early on in my career, this is about 2000 and 2002 and 2003, I thought that maybe I will get interested in the nerves and anatomy around the prostate, which will possibly make me a little bit better, more planned surgeon. And I had heard about the stories of Dr. Walsh, who worked with Dr. Donker and started the concept of nerve sparing. That same thought process was going on in my mind, but I didn't have access to cadavers. So I was first interaction started when I was in California. And then when I came to Michigan, and I found cadavers in about 50 miles away. I was in Detroit, and Michigan, Ann Arbor, was there a medical school, and medical school had some ENT surgeons were practicing some head and neck surgery in cadavers, and they had plenty of money. So they used to leave the cadavers after they have done the head and neck part. I had friends, I made connections. I thought, okay, once they are done with it, can I use the pelvis? And I got it free. Sometimes I had to pay some money. And I started going there on the weekends and started understanding the anatomy the way I thought it should look during the surgery, because all the anatomy which I was seeing was a formalin fixed tissue, which doesn't give me a texture, doesn't give me any connection to what I'm doing during the surgery. So this was the first study in which I focused on the neuroanatomy, and I could show the nerves in a much more detailed manner. So this was the first paper. And that gave me the foundation that if I get good in anatomy, if I can individualize the surgery, because Mr. X's cancer may be different than Mr. Y's cancer. One cancer may be deep inside the prostatic parenchyma and the other may be pouting out at the apex. They are two different cancers, and we have to individualize. And then the third was technique. Having trained in India, in UK, in different parts of the world, you learn there are little bit of a technique which has an impact on healing. It may not have had an impact in healing when I was doing the bowel anastomosis. Even there it was, the leakage can happen in the bowel. But in the nerve tissue handling interaction, I had to be a little bit more technique oriented. So all three things combined, I thought should be my focus for my career on one organ. And when I started focusing on the anatomy, the three things stood out to me. And I want students to now think about, I'm bringing the second concept, that is the hammock concept here. What magical information Dr. Walsh gave us was that there are neurovascular bundles on the left and the right. And if we save the bundle, there is a good likelihood of preserving the erectile function. So after looking at the anatomy, I started thinking there is a little bit more than the bundle concept here, and I should focus on. And then the second thing was, I wanted to know how is this bundle lying in the tissue around the prostate? And I realized that there are layers within the lateral prostatic fascia, which may have an impact on how I approach the neurovascular bundle. And then at the end, the apex. And that is where I'll bring back the concept of harness. So anatomical focus beyond bundles, I want you to visualize these images, which are mainly from the cadaver, and some of them done by me, some of them given to me by my colleagues and collaborators across the world. This is from my friend Atsushi Takinaka. This is the bifurcation of aorta, and what you are seeing here is a prostate here, bladder here, and this is the aorta. And I want you to focus on, can you see my cursor? If you can, just give them thumbs up. So this is what we want not to damage when we are doing RPLNDs, to preserve ejaculation. That is what the nerve sparing procedure is. At least in the bifurcation of the aorta, we don't want to damage the sympathetic hypogastric plexus. And from there, hypogastric nerves are going left and the right side. And here what we are seeing in is sacral 2, 3, and 4. That is the parasympathetic system, which is sending branches. And these branches are intermingling around the prostate in a pelvic plexus, hypogastric plexus, or we will call them in hammock as the time evolves. I will show you why I'm calling it hammock. And they are all intermingled in the tissue around the prostate. When you look at the neurovascular bundle from the left side, and here you can see it from the left side because this is a cadaver and I had a luxury of removing the whole pubic bone here. You can see the prostate, you can see the neurovascular bundle, but you can see multiple branches coming and joining, even up to the distal prostate. You can see that the branches are joining the plexus. This part I started calling at proximal neurovascular plate. This part I started calling the predominant neurovascular bundle. And then the rest were smaller nerves, which were intermingled in the fascia, and I was calling them accessory nerves. So this is the proximal neurovascular plate, which is just on the lateral side of the seminal vesicles, right, very close to what we call the bladder neck. And you can see in these anatomy dissections that this is not one nerve. There's a plexus around the prostate, and many branches are intermingled with each other. This is a sum total of sympathetic, parasympathetic, some somatic in that area. Little controversial, but they are there. But they all are not color-coded. As a surgeon, I don't know which branch is an erectile, which branch is an orgasmic, which branch is a bladder function, which branch helps in ejaculation. So that plexus concept was important to me. And when I started looking at the predominant neurovascular bundle, you can see that the predominant neurovascular bundle exists. In the right picture, in the right video, I will show you exactly where it is hiding. That is the predominant neurovascular bundle. You can see it. But in about 50% cases, the dominant bundle may not be in the posterior lateral aspect. And that realization itself was important for me to know that we have to think beyond the bundle concept. So what you're seeing on the right side is the predominant neurovascular bundle. But 50% of the times, the dominant branches and dominant branches which are kind of managing the sexual function may not be right there. And you can see, I kind of have a good feel as to where the predominant bundle is lying. And if that is all what I have to save, I can save it in a more number of cases because I know where they're hiding. But then came the concept of the accessory nerves. And I started looking at the radical sister prostatectomy specimens and the cadavers. And this is the sheet of tissue which was covering the prostatic capsule with intermingle with the nerves and muscles and veins and the loose connective tissue. And we stained them for the SA100, and you realize that there are multiple nerves in the anterolateral aspect of the prostate and in the undersurface of the prostate. So I made the two concepts I'm taking you right now. We have to think beyond the bundle. There is a bundle, we can see where it is, but if we just save the 50% of the whole neural inflow and outflow, we will not be that successful. Second thing is nerves are like in intermingled accessory nerves in the anterolateral part where we don't expect them, and they are also present posterior to the prostate. That is where I started bringing up the concept that nerves are more like in hammock, and prostate happens to sit on that hammock. And in order for us to do a good job in nerve preservation, we have to think about these connecting small branches and try to save them all. Try to lift prostate away from this hammock rather than dissecting the hammock away from the prostate, because this is very sensitive kind of a tissue. Not only that, the cadaveric dissections helped us, but there is a new kind of an imaging, which is known as a DTI. It is a neuroimaging in which neuroscientists are tracking the tracts in the brain. We try tracking those same tracks, not just us, but our colleagues and other investigators have looked at it. And you will appreciate in this picture, other than it being very vivid and very colorful, there are many fibers which are floating around and they are not like one bundle. So that brings me to my hammock concept. And this hammock concept has been very well depicted in this video, which we have put together using a 3D modeling technique. And the second generation of this video is about to come, and it will be launched in next couple of weeks. And the credit goes to one of my new fellows, Dr. Sneha. Dr. Sneha Parekh is from Gujarat, and she is spending fellowship time in research with me. And she is working with basically 3D modelers in making this more updated, in bringing in the anterior concept in this, that where the branches are anteriorly. She's bringing the muscles and everyone. But this is what was done long time ago in 2010-ish, that the hammock concept came. Then the second thought which I had to deal with it is that how is this hammock lying within the layers? And you can appreciate here that there are many layers around the prostate, and that's the second concept. There are layer within the layer in the lateral prostatic fascia, and we need to be aware. And this work was actually done, and you may know Dr. Rajiv Yadav. He is in the Delhi area. Raju was, I think, a gold medalist and AIMS topper getting into the MCH course. He came out and he did a fellowship with me. Such a quiet, such a gifted person. He would go and look at the pathology afterwards, and the cases in which I'm not doing a nerve sparing because they have a Gleason 9 or a Gleason 10, he will sit down and study the pathology with the pathologist. And he started looking at the pattern and the fascia around that couple of millimeter thick fascial tissue outside the capsule. He came up with the science. And he and I basically developed that there are grades of nerve sparing which is possible if we understand the anatomy around, and there is a plane which is traveling just outside the prosthetic capsule. That is an aggressive plane. I can get into it. Then there is a plane which is just outside the veins and the vessels. About 5% of the nerves are deeper in this plane, and most of the nerves are outside this plane. And then there are different layers within the layers, and ultimately the lateral most part was what we call the levator fascia, which is covering the levator and eye muscle. So we got some guideline looking at the anatomy, looking at the pathology, that there are different planes outside, but can I see those planes? And that was the next discussion. But first thing we did was to simplify the concept. And I think in 70-80% of the times I can see the plane where I am. I definitely can see when I'm hugging the capsule. I know when I'm around the veins. And if I am in doubt and in inflamed tissue, I will cut through the vein, see the thrombophlebitis, see the venous lumen. Then I know I am not too close to the prostate, but I'm not too far from the prosthetic capsule also. But this concept has been validated, a lot of people have looked into it. And this is a real-time guide to the surgeons that how to handle the plane discussion. And if in doubt, you can get back to the fundamentals, go back to a normal area of tissue, get in the right plane, and develop the plane laterally. We wrote a few papers on that concept. We created some videos looking at it. So this is the levator fascia. This is what we call the second zone, is an incremental nerve sparing. Then the next plane is lateral to the vein. And then finally, we come to the deeper to the plane. These are the different grades of nerve sparing. And I want you to see, if you can, that how these nerves are arranged. And on the left video, I want you to see that there are many nerves there. There's not one nerve there. And this is a real patient. I can show that how the neural anatomy is. And on the right side, I'm showing the plane within the plane discussion. But on the left side, if you focus, there are more than one nerve, you can see it. And there are planes which you can see in good tissue. And I will try to show you, this is a plane which I have found very recently. I think in last 10, 12 days, this is a patient in which I'm concerned about whether should I save the nerve or not. And you can appreciate that there are plane within the planes, and I'm still not at the capsule. And the credit for this video goes to my other two fellows, both Vinayak and Adriana, and they are the clinical fellows. But you can appreciate there are different layers within the layers. And as long as we are cognizant of the layer concept, you should be able to modify the operation. So I am teasing out one of the layers here. And on the lateral side, you are yet not seeing what you call the levator muscle. So we talked about hammock, we talked about the layers, we talked about anatomical landmarks during surgery, which can help you in identifying and choosing the right plane. Then we come on to the apical anatomy. And I think the apex is where the most of the operations are made or are not made. And you can have, I will come back to this picture on the top again, but this is a cadaveric dissection where you can see that the final nerves which we are trying to save are here and actually in this part. And you need to understand that the apical anatomy is very kind of evolving. Not everyone has a consensus that most of us, we believe that the posterior laterally that the nerves are going and they are the erectile nerves, but there is some data coming that certain branches may be diverging a little bit more anterior and they may be more cavernosal nerve rather than a spongiosal nerve. So this paper says that they are more anterior. And as you can see, as nerves become distal near the apex, they are kind of going a little bit more anterior and getting pulled behind. So that is where the hardness concept will come. And we wrote different other articles, mainly pertaining to the neuroanatomy and the anatomical layers. So I got to the point that I understand nerves a little bit better. I understand the hammock, I understand the layers, and I also know that the apex is very critical. Then I had to kind of focus on how to individualize the surgery. Not one operation is good for everyone. The left side may be a different operation and the right side may be a different operation. So we started leveraging from what we call an imaging. And I worked with a friend of mine, Francisco Proplegia in Turin. I would do the imaging, I'll do the MRI, I will create a secure network to get those images to there, and they will do a 3D model, and you can see a 3D model on the right side. I had two Italian fellows, Alberto Martini and Ugo Felagario. They started working in collaboration with us and we started modeling. And I went down to the basic fundamentals myself, that each case, after looking at the DRE, after looking at the biopsy, after looking at the MRI, I will make a mental picture and sometimes I will put it onto the paper and these are the picture, the way I'm looking at the cancer and then the way I'm looking at the final field, how it should look. Meaning in this patient, I'm seeing something there and we are working on a very high resolution MRIs. I'll not go into that discussion, but there is a new set of French fellows with us, Jordan Nassari and Flora Bath, who are working on a 7 Tesla MRI and redefining the imaging of prostate. Hopefully that we will talk some other time. I'm not going into that, but we created the algorithms, we developed the nomograms, and we knew what kind of a nerve sparing we want to do. We had already defined that I can tailor the surgery to grade 1 to grade 4. I now have a risk tool which tells me based on the preoperative number, what should I do? Should I be very aggressive in nerve sparing or should I be just not doing any nerve sparing? I had some logic, I had some tools which were using a preoperative information and imaging and the data. And now we are working with a group of people who are looking at an artificial intelligence to model it all together. Then came the part about the technique. And there are a couple of technical issues I will tell. One is how you handle the tissue may have an impact on how that tissue will heal. And especially if you're looking at a very fine fibers, those fibers may get avulsed, torn, burnt, or become ischemic. And the other part is we have to think about inflammation as one of our enemies, that even after we are gone and done, the tissue which we are leaving behind, if it is very inflamed, that inflammation may have an impact on how things heal. So I do believe that this is something which can be appreciated and practiced, but technique and tissue handling has an impact. I came to a discussion about when I'm doing the nerve sparing in the technique, are there specific areas where I have to be worried about? And as I say, entering into a plane right at the base where the non-Villiers fascia kind of gives in and way to a secret tunnel, which I call the prosthetic triangle. And this is something which I had thought about in 2007 or something, that once I get into that plane, and if I am all given a green signal to do the aggressive nerve sparing, this plane will lead me to almost the whole operation. And we created some, we are working on an atlas. Hopefully that atlas will come out this year. So this is my concept about how the nerves are at the base and how I get into the tunnel. This is one of the examples that how I approach the nerve sparing. I'm aware that there are not many nerves which are originating in the midline. They are coming from the side and they are making a plexus, but they are not in the midline. So I go from a safe zone. I will develop a plane and then I will slowly tease it out. I'm very fond of using scissors and the sharp instruments rather than the blunt instruments because I can control what I am doing. I'll get into the right planes. And depending upon what the goal is, whether I want to do a grade 1 nerve sparing or grade 2 nerve sparing, I can choose to. Sometimes it's not a bad idea to cut a blood vessel or cut a perforating vessel because otherwise you will create a flap. And I already have a MRI, I already have a visual in front of me that is this the area where the cancer is. If I know that the right mid prostate, there is a cancer there, then I will start getting a little nervous and I will very gingerly try to open the planes. If they are not yielding, I will cut it through. So technique is being refined, technique is being practiced, and understanding of the anatomy is helping me. And then it comes to another case in which I am little worried about this area. So I am deliberately leaving some tissue on the specimen. I can get into a deeper plane. I know I'm cutting a blood vessel or some kind of a fiber, but having a field which is clean like this helps me in getting what I need. So technical refinements, understanding anatomy, respecting the neural tissue, and starting from the point where there is the least amount of neural tissue, that is in the midline and the posterior aspect, I will come on to the apex. And we looked at the apex, and every year I used to say, this year I'm going to focus on X part of the anatomy. We are coming back this year again to the year of apex. Like in Chinese thing, there is a year of dog and there is a year of some other thing. This is a year for apex for us. We are going to focus on apical anatomy, and the person who is leading in my program, his name is Jordan Nassari. He's a French fellow. He's here for us for 1 year, and we will look into it every possible way, how the variations happen, what the muscles are, how nerves are integrating it. So hopefully we'll have a little bit better understanding. But key here is apex is a critical part. Don't try to finish the operation on one approach, one vantage point, one vision. Try to tweak it. Look into the left, right. I believe that circumferential look, which a robotic platform allows you, possibly gives you a better control on the process. So we developed the retroapical and circumapical approach. This is a video, and it will show you that in certain cases, I can do this wholly. You are seeing the undersurface of the prostate here. And I don't recommend this for anything else, but you will appreciate later on that the nerves are converging in the posterior aspect. And if we do it everything under vision, it is less likely to damage the nerve. And if we save or maybe gain 0.5 millimeter, 2 millimeter of length from the urethra, if I can steal it, this is worth for us to go into that mode. So we started looking in every now and then that what are the different technical refinements we can do to kind of get to the point. And between 2005, 2011, we went into discussions and looking at the milestones. Things which stood out is we have to think about hammock and not the nerve bundle. We started thinking about how to know the layers within around the prostate. There are layers, and in good case, I can show the layers. Third thing came out that we have to be very deliberate in planning the operation. Not every patient will get the same operation. You have to be aware. Then the last thing which was coming out, it's about the continence, and I have not focused on. And the concept was that is it all muscle? Is it the urethral length? Is it the support system? Is it the surrounding fascia? What contributes? And very early on, I was interested in an anterior support. And I really thought that the anterior tissue has an impact on it. And that will bring me to my third discussion, that is the hood concept. Right before I start, I want to know, do I have some time or should I just sum it up? Okay. So
You have
harness, okay. Harness, hammock, layers, and then now comes the hood concept. And I couldn't have found a better picture for, I'm an Indian cricket fan. So this is a hoodie I wanted to find. And Vinayak should be giving credit for that, that I got inspired by the radius sparing surgery, and I have done few. And there is no doubts in my mind that radius sparing surgery gives an early continence. When I look at the radius sparing surgery and the other kind of surgery beyond 3 months, beyond 6 months, there was not major difference. But at the day of catheter removal, I found that there was a difference. And I started thinking about, is it a concept of an space or is it a concept about the structures? So it's not the radius space which is adding value. It is the structures which are in the anterior part of the prostate are making a difference. And I thought we should focus on it. And can I save those same structures without complicating my surgical approach too much? Because on one side, we were saving the radius space, but the second time, I am always thinking about the most concerning structures in this entire operation. The entire hammock concept is posterior to the prostate. So it's not just the radius space, it's the pouch of Douglas also, which has an importance. And if I get into a very narrow space, and we all are surgeons, if in doubt, make a bigger incision, get an exposure and do what you need to do. That principle applies this operation also. But instead of getting stuck into one approach, I wanted to kind of develop an approach in which I can possibly save all the structures which are being saved in the radius sparing, but do it with a little bit of a more elegance, little bit of a more freedom, more versatile ability to modify. And one of the things which I used to worry about it, and I have had cases of my own, dealing with the median lobe and dealing with a small pimple of a benign tissue which is detached from the main median lobe and is present into the trigone, and not being able to see the ureteric orifices. All of that was kind of bothering me. And I wanted to see if I can get a similar kind of a result in continence without going from the space of Douglas, rather getting in the front, yet saving all the structures. So this came into surgery in motion last year, and all the credit goes to Vinayak. So Vinayak and I sat down and started looking at the data, and we looked at the anatomy, we looked at the front of the prostate, and we realized there are structures which are anterior to the prostate, which we normally just for no good reason sacrifice it, should be preserved. So Vinayak, Sneha, and myself sat down and started marking the tissue, which is in post-operative images. And you can see what I have saved and what is left in front of the prostate. There's a relevant tissue. So I started developing this hood technique, which is in saving the entire anterior detusor apron. And obviously, anatomical foundations for these were already laid by Dr. Bob Myers, who is a close friend, a gifted surgeon, and a very good human being. And so this is the hood. I am saving the hood in anterolateral aspect. Everything is happening under vision. And you can see a lump of tissue here, maybe if you can appreciate in the right side. Once we have done this, we will sometimes cut it coldly, or sometimes we will do it after a suture. I usually put in a suture, but usually do it little later because I want to be cognizant of the blood vessels which are, or the nerves which are coming from the anterolateral aspect at the apex. Gaining some urethral length is a good idea. Getting as much of a length of urethra along with saving all the hood structures. This is what I'm left with at the end of the operation. If I do a good hood, and you can save the entire space of rigid structures, everything which is coming anterior lateral is saved. And I still had an opportunity to come from the front, and I will do the anastomosis, and that anastomosis can, I'll not show the whole anastomosis, but you can do it. Whole anastomosis like this. You can save the bladder neck if you want to. You don't save the bladder neck if you don't want to, and reconstruct it later. And we have shown that at the apex, by saving this entire thing, the last few millimeters of nerves, if they are saved, I think that is my harness concept, that not only just posteriorly at the anterolateral aspect, in the front, every structure, if we can save, it's not prostate, we should try to save it. And that brings me to this harness. Can you see these nerves? And it's just like you have to appreciate the proximity, and this is where the entire operation is defined. Even if I damage some nerves in the proximal part of the prostate, there are many sub branches going to join. But if I cut this thing, that whole operation got destroyed. And nerves are not that easily visible. So I'll bring it back to our free solo discussion. The guy who climbed without a harness did it because of several reasons. He broke down the problem into many different small pieces. Dropping the bladder has its own nuances. Seminal vesicle has its own nuances. Bladder neck has its own nuances. Left side pedicle has its own nuances. Right side has its own nuances. Apex has its own nuances. Anastomosis its own nuances. We have to break it into pieces. This guy moved into a Yosemite in a small pickup truck. He started making a journal for each thing what he was doing. Every day he will practice certain part, and he wrote a big detail. He worked on his skills. He will put up a pull-up bar, and that may be the reason that pull-up bar came there. So he had a pull-up bar installed here, and he used to work and practice each move. I still remember in early on when I used to do a laparoscopic prostatectomy, I had a trainer put into my own garage, and I will practice each suture. The left suture will have to have this grip. You have to twist this much. So just like he had grips, we have moves we have to practice. We have to have a plan B for the move. We have to have a support structures. And that, I think, was the theme of my entire talk. Pick up a problem which needs a solution. Define it into the details as much as you can. In my case, I thought the nerves are more complex, and the hammock concept came. I knew what layers this hammock was hiding. I was happy to find that there are steps I can do technically to A, plan it, and B, be more delicate with the nerves. Hood idea gave us some boost in the continence. And focusing on the apex, this is the year. Hopefully, I'll have some more details for you guys. And I have been lucky, as they say, that we all are looking over the shoulders of the giants. I was lucky that Dr. Walsh came and has given me feedback. And there is a lot more to be done in this operation. And I must thank all of you for spending time with me. You guys, I mean, my heart is there, and I just happen to be 10,000 miles away. And if there is ever a need, I'll be there, just coming there. I'll sum it up by just thanking Anil Alhens. And the time which you spent in trenches, you never forget. And I cannot forget the time which Anil and I spent. Anil had a lot of confidence on me, but I made an IVC puncture while he was assisting me. And he and I calmly pulled it together. After 14 days and 14 transfusions, that patient walked out 30 years ago. And Anil remembers, Anil was calm then, Anil is calm now. Thank you.
Thank you. Thank you, Dr. Ash Tiwari. It was wonderful. I don't have any words to express I would ask now Dr. Mallikarjun, Dr. Anil to have their brief comments, and then we will begin with the question
No,
answers.
it's a tremendous. You see, I tell you, I've been listening to Ash talks on nerves past 10 years. I think your first talk started on 10 years on this hammock, this thing which came on 10 years ago. And every time you're adding some new point to it. That is the thing what I've been observing. And this food concept which you started off in the last 2 years or 3 years, it shows that it is adding and adding. And I think I'm just awaiting, which I still believed. The reason you may preserve anything around the prostate, and if you damage at the apex or at the entrance where it goes around the urethra, the whole thing is of no use. That's what I still believe in, and you're going to give me the answer next year possibly. I'm looking at that apex part of it, and that is going to be the most crucial. I believe I'm most likely going to believe that. Another thing, Ash, I just want to have one question. That's a comment I had, and one question is, you've been operating some Indian patients too in your practice. How do you define this chronic prostatitis scenario, which happens to be, there is some element of adhesion of this fatty tissue around in the prostatic capsule. I don't see that sort of a planes like what you can demonstrate in many of your patients. How do you feel, and what is your opinion on that?
I think that is where the Deepak Chopra concept comes in. Inflammation, I do believe, and I agree with you. I think inflammation, part of it could be that we are very patient. I mean, I will not go to a doctor till it is really painful. So that preventive mindset, which we see in patients here, may be presenting the diseases early on, while we just deal with it. But when that same problem has been there for 5 years, then that tissue is inflamed. So that could be the delay in presentation discussion. But then I think as a surgeon, that day we have to decide. And I'm a big fan of venous plane, meaning even I can know that I'm inside a vein. So in an inflamed tissue, you see thrombophlebitis, you see even some of the phlebolytics. So if you stay in that plane and err towards the capsular side, then you are saving most of the nerves. I mean, not all, most of the nerves. And that is where the tissue goes. And if you are pretty certain that this patient has a big chunk of cancer on that side, and we also tend to have a little bit more ECE, at least in my cohort when I was looking at it, patients who were Indian in origin, both from US and in India, we kind of delay in presentation. I think so. We need to just be more active and proactive.
I love your statement. If you're seeing blood, you're saving nerves. I love that statement of yours. You always make it. If you're seeing blood around, means you're saving more nerves.
As long as it's not in,
of course,
as long as it's not in the IVC.
I'm not in the IVC. I mean to say into the veins around the prostate. That's it. No, you've made that statement many times, and I believe it. I said all the time. I've seen patients, we open up into the veins and get the phlebolytics, push the phlebolytics away and go ahead with the surgery. And you can see the endothelium on either side being saved. Yeah. And that doesn't really cause a real problem in the postoperative period also. But anyway.
I mean, you're right. Absolutely. I mean, and then with the pneumoperitoneum, it doesn't bleed that much anyway, but you know where you are. You can reset your landmarks.
Absolutely. I think you made more and more layers and made it so clear. I don't think anybody can, there's nothing like not understanding what the nerves meant around the prostate. I think it's such a beautiful display of your whole things and your skill set of presenting it so well. Fantastic, Ash. I really enjoyed it, and thank you very much for this.
Thank you, Dr. Mallikarjun. Seeing Dr. Tiwari's surgery, it looks like surgery is not just a skill, it's an art. So how an artist draws a painting, it looks like that when seeing your surgery. So I would request now Dr. Anil Ellens to give his brief comments before we start the question answer session. Yes. Dr. Anil, please come in.
Anil is there?
Dr. Anil? I think he is probably in some emergency. He just messaged me that there was some emergency. He might be coming soon. So we will take up a few questions. We don't have many questions, but there are there are some studies now, because sometimes even if you do a very good robotic surgery, still you would not be able to visualize the nerves and the network of nerves. So there are certain imaging modalities that have come, and I was just going through this one of the articles where Dr. Tukar was telling about the different imaging modalities that can come up in future. That is the multiphoton microscopy or the confocal microscopy or the optical coherence tomography, to know exactly intraoperatively the network of nerves and how to spare them. So any comment on that, Dr. Tiwari?
I think this is a very good kind of an topic. Prokar and also Bernardo Rocco has been working a lot on this concept that it's like a firefly for nerve sparing. If we can do something in which we can see the plexus, and more importantly for me, and you and I both know that the nerves are within the layers. So I don't want to be too close to the layers, but what I do want to see is that the edge where I am cutting, is there a cancer there? So not only multiphoton microscopy, not only confocal microscopy, not only Raman effect, not only optical coherence, but PSMA combination in an intraoperative way with a change in the wavelength of the lens can help you in recognizing, are you dealing with the T3? And all that combined, I think, will help you in defining the nerves better. These tools will be developed. These tools will have to be practical. One of the things which I'm working in, and I always call my team member, that I need a cool zapper, meaning sometimes there is in one small artery, one small vessel, and I don't have to buzz them. I can cool them and the crystals will form and they will be in the least damage to the nerves. So I want a cryo-selective probe or a grip, which will be my, instead of reverse cautery. So these are the technical nuances will converge on the robotic platform, and I think will help us becoming a better surgeon.
What's your opinion on NeuroSafe?
Yes, Dr. Mallikarjun, yes.
No, I just wanted his opinion on NeuroSafe method, what has been advised now.
Yeah. So there was another article on NeuroSafe where they do a frozen section biopsy of the prostate and just see whether they have these nerves spared or not. So any take on?
So I do know NeuroSafe, and I was lucky to have Hamburg team come and spend time with me in 2014, and they initiated our NeuroSafe. While we look at the rest of the data, I can tell you one thing, which I'm pretty convinced about NeuroSafe. NeuroSafe makes me a better surgeon. I'll tell you why. I do about 11 surgeries a week. 7 days later, I get the pathology, and some of them have a positive margin. I don't recall what I did exactly in that case. But half an hour later, where I'm waiting like this, waiting for the path, and they tell me that it is negative, I celebrate, and they tell me it's positive. My mind remembers what I did or what I didn't do right. So because it's an actionable information, I go and remove more, whether it's useful or not, I have to look into it. But my mind is kind of thinking about, hey, you know what, that left side, maybe you should have just not got so close to the capsule. Or you underpredicted, you thought the cancer was on the right side and it was on the left side apex. It was on the apex. You thought it was only on the right side. When it is at the apex, think about apex on the both sides are problematic. So it definitely makes me a better surgeon because of an immediate feedback. I mean, you make a mistake, 10 days later, someone punishes you, you don't even remember what did I do. But here I kind of make a note and I come back and I reflect upon it. So next time when I feel the same issue, I can do it. I do feel a little bit, I mean, it takes time to establish a good NeuroSafe program. We have a good pathologist, Dr. Ken Haynes, who has put it all together. And Alex Hess was the one from Hamburg who came and established it. I think NeuroSafe has other potentials also, but I use it.
Yeah. So another potential is probably by the augmented reality imaging, where you just integrate the MRI into the robotic console and just go with the imaging, MRI imaging. So yes, Dr. Tiwari?
I think it will happen. I mean, I think right now, what the tools we have, AI-based tools, they are a little bit not that evolved, but evolution will happen that if a car can park itself in a very small parallel parking area, you can bring in MRI images, and that will only make me a little bit better. I am doing that so-called virtual reality by having on the left side my MRI, right side my predictive nomogram, the left on the other side and ultrasound images. I'm trying to look into while I'm doing the surgery at the console, but having it onto the console will make things easier. It all depends on how seamlessly we can integrate it. It's just waiting to be done.
All right. So you talked about the cryo. So there are surgeons who are trying to work with hypothermia. Some are doing with laser dissection, carbon dioxide laser dissection, and and some even are doing clipless kind of surgery where they just put a temporary bulldog clamp and then do the whole surgery. So what are your comments on these techniques?
So when we talk about the technique, energy is in one of the discussion points. And I have done many surgeries with the bulldog clamp. So that is a real thing. And off late, I have been thinking about just cutting it sharp, deal with it, and then suture the bleeder or clip the bleeder because it's not major. It just doesn't look pretty. But so I have been thinking about the clipless part of the discussion too. I have done many cases in which I will, at the entry into what I say, that entry into that tunnel at the base, you need to sweat it out or bleed it out. And you just cut it sharply. And then once you get into that plane, everything else will follow itself. So I think these are small tools which are being developed. So laser is one, hydrodissection is one, hypothermia is another one. All of that is to A, preserve anatomy, B, preserve physiology, C, reduce inflammation. And the same discussion can extend over the stem cells and the growth factors discussion. But there is a lot happening in that field, which needs to be very cautiously looked upon. But these all look like in very viable areas for us to push.
Right. As you rightly said about the growth factors, there are a lot of things going on with the amnions and even the biological membranes, which have neurotrophic factors, and then even shellfish. So any work being done in your university?
So some of you will know Vinayak is from Mumbai. He has just become a faculty here in our department. He finished his clinical fellowship, and he is leading two different kinds of amniotic tissue intraoperative to provoke healing. And we have got multiple clinical trials going on in this.
All right. Because I remember when I was an intern in Calcutta, it was in the 80s, where we used to put amniotic membrane over burn patients for regeneration of the skin. So this amniotic concept is very, very old concept. And I think this is, again, probably coming in. There was another thing that probably, which technique, is it a retrograde technique or the antegrade technique is a better technique? Some people say that if you do it retrograde, then you would likely to preserve those nerves and all those, because you will at the end ligate the pedicle. So is there any difference between the retrograde and antegrade approach?
So again, I have done it, and I am not a big believer of limiting surgery to a particular name or a particular approach. If there are cases in which I can see that there are not good planes, I will go and finish the apex first. But I do believe the mobility helps. And if we think that the most critical part of my operation is at the apex, why not fight that battle a little later when I have a better orientation of everything else? That's the driving discussion in my mind. But I have done it. If things are not going the way I want it, I will stop. I will go and tie the dorsal venous plexus. I'll get onto the apex. I will release that, and then I'll come back. So I don't think we should, as a surgeon, limit it that I'm an antegrade surgeon or I'm a retrograde surgeon. We are all prostate surgeon, and we will modify it based on whatever works for that individual.
We have heard Dr. Patel sometimes saying about the landmark prostatic artery identification and then going exactly on that artery and ligating that. Any take on that, comment on that?
I mean, I think that is the same concept that you need to know the layers around the prostate. And you remember we showed that the vessels are in the second zone. And Vip is a very gifted surgeon. And you saw that similar artery in one of the images in which I was showing that how it was going. You can identify that. And these are the small things which you can tweak it. And after every 1,000 cases, you start appreciating something. It has a value. And he definitely uses that as in his retrograde approach towards this. So vessels around the prostate are the travelers or perforators. That is what we have to differentiate. If we confuse between these two and don't cut the perforator, I think it creates a flap. So don't be shy of cutting a blood vessel. Blood vessel is not nerve. So that is the mindset in this, but that is a good anatomical landmark. But if I am doing a grade 1 nerve sparing, I shouldn't be seeing any one of those arteries because I may plane deeper to them.
In the beginning of your talk, you said that nerves are not only important for erection, but it is also important for orgasm and ejaculation, because the hypogastric nerve, which is responsible for the orgasm part of the sexual function. So have you done any studies besides erection, knowing the erectile function, on orgasm and ejaculation of these patients post-operative?
So I did publish early on one paper on orgasm. And if I remember the data correctly, that about 90% of the patients do regain their orgasm back. About 5% of the patients have a hyperorgasmia, which is more intense and sometimes touching pain. And a small number of patients have what you call, they have hypoorgasmia. And so we did publish that paper, and I'm trying to find if we can find the orgasmic function one, but we have published that paper long time ago. Actually, about 10 years ago, I was thinking about doing some things to preserve ejaculation. So I was trying to think about anastomosing it, the ejaculatory ducts into the urethra. And at least one patient I remember had it. So this all is possible, but not right now.
All right.
But orgasm comes back in majority of patients.
Right. Because I think that is important, because
it's a dry ejaculation. It's a dry ejaculation.
Ejaculation is probably not, because those two are totally different physiologies. So if orgasm is preserved, then probably the sexually function is preserved rather.
Actually, that brings in a totally different complication also, which we don't talk about, climacturia. Climacturia is a little bit of a urinary leakage at the time of ejaculation. So the continence has a different level. When it doesn't leak even at climacturia, I think that is when we think, and that's the reason all the innovation which we are doing, we are not perfect yet. I mean, I think there's a lot of tweaking needs to be done, and we just need to look at the data, see what may be contributing to it, and just start working on one step at a time. But climacturia is something which can happen.
So another, I think one last question probably. How do you decide to go in which layer you would go, like intrafacial or interfacial or even extrafacial? So would you like to have, because some of these researchers have even devised a model of selection score of oncological safety to whether they want to go into intrafacial or interfacial. So any comment?
So this is the model I use. I think, so there are 3 papers which have come out of Alberto Martini, which looks at the risk of extracapsular extension, and it gives a nomogram. And here on the right side, you can see if there is a less than 10%, I will go and do the very aggressive nerve sparing. If it is more than 73%, I will just not do a nerve sparing. There comes the gray zone here. And then I use logic. So let's use logic. 45-year-old guy who has a Gleason 7/4+3 has about 20% risk of extracapsular extension. I would err on the side of saving more nerves in him. 78-year-old person who has a Gleason 8, I would err on the side of something else. So you have to individualize based on the discussions you have with the patient. If patient is most likely to have radiation afterwards, there are patients who will have it. So then I will do everything possible for that patient to be continent. So even if he gets a radiation, he has a better quality of life. And so you tweak it based on patient's own interactions, their own advices. But this nomogram gives you a very good feel. We are working on a super nomogram in which we can you can feed in the data and it will churn out. And hopefully my team is working on that right now. But this is a very good nomogram. You put in biopsy information, PSA, you put in MRI information, and it churns out what's the likelihood.
All right. So it will also depend upon where the malignancy is, at the apex or at the mid or the base of the prostate.
So this is a side-specific discussion, right and the left side, and you know where the biopsies are positive. I must say, if it is Gleason 8 or 9, that entire side is problematic. So don't try to be too cute on that patient's right apex and all those things. That side is, and the most likelihood of getting a positive margin is at the apex. So if it is distal, even our current imaging is not perfect. And the most frustrating for me is that right side was all the cancer. I got a positive margin on the left side.
Oh my God. Yeah.
And it happens.
Thank you. I would request now, Dr. Malik, if you have any question or any comments. And then
I tell you, every time I'm just waiting for the next year talk wherein I can look at the apex part. I'm just waiting for the next advancement from Ash. Thank you, Ash. Thank you very much. It was a fantastic training session for our residents. Thank Shivam for taking this opportunity from their side, from SMS, and thanks for your time from my side. Thank you.
Any of the faculty has any question, just please come in. Now, then I would request Dr. Tiwari to give his last surprise, because one of my colleague friend, Dr. Nachiket, had told me that he has a very...
I didn't prepare it. Yeah, basically, I'll tell you, he requested that if I can share some urban photography.
Yes.
Actually, so I'll just give an emotional part of it. I lost my dad very early in my life, and meaning when he was barely 65. And he was my best friend. I'm the only son, and he was a photographer. And I used to be his caddy. So I never officially learned from him, but messing up a lot of things for him, I just pick up camera and I try to take pictures. And only theme I follow is take pictures of nature. Nature never complains. If I take picture of family, they always say that I didn't take it at the right time. So that is my advice. And if a picture makes me smile, I will share it. If it doesn't make me smile, there is a better picture. And hopefully I will send you guys some pictures, but I just didn't know that this will be the right platform to.
Nice,
so,
perfect.
but they are on the Twitter or Instagram. Some of the pictures are there, basically Instagram, and they just make me happy.
Thank you.
Thank you very much.
Thank you very much.
It's a real proud moment for us, for the Department of Urology, SMS also, to have you on our platform and deliver this talk. Thank you very much, Dr. Tiwari. And thanks, Dr. Mallikarjun, Dr. Keshamurthy, Dr. Anil Allens, and all the faculty and everyone who has joined us today. Thank you very much. Thanks a lot. Thank you.
Thanks a lot. It was healing for me. Thank you.
Thank you.
Thank you. Thanks.